Good. And we are live.
Hello, good morning, everyone, and thank you for joining us with this exciting webinar discussing COVID, mental health, and the vaccine. We're all aware about how devastating the pandemic and the COVID infection has been, particularly amongst the BAME communities. And we just thought, as a group of psychiatrists and clinicians, that would come together and sort of look at predominantly the mental health aspects of this infection and pandemic, and then to also address the concerns around the vaccine. We know there's hesitancy amongst the BAME community, and then we thought, why don't we have a conversation about this? We think it's important to share our concerns. We think it's important that people have an opportunity to ask questions from members of their own community. Now we have a fantastic lineup of speakers from very diverse backgrounds. I would encourage you all to make use of this opportunity to ask them questions, share your views. We've got our email address, and then we've got the chat box. Please send in your questions. The speakers would introduce themselves, and we may come in just to highlight some keynote aspects of their speeches. Once again, I'd like to welcome you to the Association of Black Psychiatrists in UK's webinar on COVID, mental health, and the vaccine. We need to keep the conversation going. And if I might add, it doesn't end here. Without much further ado, I would like us to go straight to the program, and we will start with the first speaker. Thank you.
Thank you, Chinwe. My name is Dr. Tim Ojo. I'm a psychiatrist, a coach, and mediator. I lead the coaching network for Faculty of Medical Leadership and Management, and I'm also an associate registrar for Royal College of Psychiatrists. So thank you for giving me the opportunity to talk to you this morning. We're talking on a very important topic, and I hope I'll use my 10 minutes wisely. Without a doubt, COVID-19 pandemic is the single and most cataclysmic global event since the Second World War. It's very likely, as we talk about the 21st century, we'll be talking about life before COVID and life since COVID, as a testament to the transformative impact it's going to have on us for the foreseeable. Today, I'm my task to talk about mental health presentations in the context of COVID. So I'm going to try and narrate a very simple and very clear story about what the issues are. We know that pandemics previously have been associated with increases in neuropsychiatric symptoms, such as confusion, anxiety, and depression. Obviously, the context in which pandemics affect large swathes of the world means people start worrying from the perspectives of whether they're going to catch the condition, and if they catch it, what the consequences might be for them. And that has knock-on consequences for their mental health. We also know that living through a pandemic, because of aspects like lockdown and social distancing, there's likely to be an increase in stress, anxiety, and psychological distress. And essentially what you find is groups of people can be divided into two broad categories. Those who have existing mental health problems prior to the onset of the pandemic, in this case, COVID-19, and those who don't. And there might be differentials in the way the pandemic plays out for them. A recent paper by Mukadem et al. Looked at a review of the neuropsychiatric problems associated with COVID-19 and found, for instance, among ICU admissions, delirium and agitation were common symptoms that were mental in nature associated with getting into ICU with COVID. As I said before, some of the issues that assail communities as a group would be about the psychological impact of social distancing and isolation. Communities that have naturally shared time together, form close social bonds, will find it more difficult to deal with the consequences of physical distancing and isolation. And we know that loneliness, particularly for people in their later life, is associated with increased morbidity around anxiety and depression. So we know that the pandemic can cause new symptoms in those with no previous mental health problems, but also can worsen mental states in those with pre-existing psychiatric conditions. So in thinking about mental health presentations in COVID-19, you have to think about what broad group are you starting from? It seems interestingly that when the statistics were done, in the first few weeks after lockdown, presentations at A&E fell, and some papers will cite as much as 11%. And I think my experience from the shop floor as a crisis consultant showed that people were actually quite worried, and the specter of catching COVID was greater risk than reward of receiving mental health care in the short term in that context. We also noticed that A&E presentations overall fell by as much as 64% in the first month of lockdown in 2020. And that tells you something about the fact that there was this new virus out. People were very concerned about it. The death numbers were going up. People were getting infected, and people chose to steer clear of mental health services. Concomitantly, it was noticed that there was an increase in mental health act assessments and inpatient admissions after lockdown. That could be looked at in a number of ways. It could either mean that people got very, very ill, not having made contact with crisis services, and got so ill that at the point they made contact, it was under compulsion. And that has some issues for us as a community. We know that historically, Black and minority ethnic people have had disproportionately high contact with services under compulsion. And then the other issue was about, there was an increase in the proportion of people presenting with psychosis, delirium, and violence. Now, this is interesting because you might argue that did people become more violent, aggressive because of the pandemic? That doesn't seem to be the case. What appears to have happened is that there was a reduction in people relatively reporting parasuicidal thoughts, or coming with suicidal ideas, or indeed having attempted suicidal acts. And as such, the proportion of those presenting with violence or delirium seemed higher than would normally be, because the proportion of those presenting with parasuicide was much lower. I think, why are these things important? Important because as a community, we need to start thinking about where we are in the different spikes in COVID pandemic infectivity, and what the consequence might mean for those who have had illnesses from the very outset of the first wave of the pandemic, who have not sought mental health care, versus those who have mental health problems prior to the pandemic, who, because of the way services have been designed to support them in the midst of the pandemic, where there's been less face-to-face contact, more hands-off kind of telephone and video consultation contact, that has consequences for the continuity of care for people. I think it's impossible within 10 minutes to really speak to the depth of the vast range of mental health presentations. But what is clear also is another paper suggests that although people with pre-existing mental health problems have presented during the pandemic, it hasn't made the quantum of severity of their illnesses any worse. And increasing also the number of people who previously hadn't had contact with mental health services who are now seeking mental health support, either through counseling or indeed depression and anxiety. And the likelihood in the short to medium term is that we're going to have an increased demand for mental health. And if we know that access issues abound for people of color, then it behoves us as community or clinicians, so community leaders, to engender supportive group engagement with local services to make sure that access issues are addressed, particularly where you have the digital divide, where people may not be wired up and connected appropriately. So there's an issue for us to think about. In summary, I need to start focusing on a pressing issue that doesn't necessarily speak to presentation as such, but is of seismic consequences going forward. So I'll say it this way. I think, unfortunately for us, the bitter harvest of the devastating socioeconomic and health consequences is far from over. I think we owe it to ourselves, both as clinicians and members of Black and minority ethnic communities, as parents, as siblings, relatives, to make informed decisions about our mental health needs, our physical health needs in the future and in the near future. I think we need to make decisions based on the facts and the science. ask critical questions, but at the same time, make decisions based on facts and science, not on fear. I think in doing this, we increase the chances of us surviving as a group to tell our stories, our unique stories, about the strange times we live in the years ahead. So in summary, what I would say I've said is that COVID-19 pandemic has brought about significant mental health consequences for communities. I think it affects those who previously had mental health problems, as well as those who didn't. I think that there'll continue to be increased mental health care demand in the near future. And I think as communities, we need to make use of the available services, need to advocate for those who may not access services usually, and make the best of our communitarian philosophy to support ourselves over the next few years. Thank you very much.
Thank you, Dr. Ojo, for that. So to take away the key aspect of your speech is the significant impact the COVID pandemic has had on mental health of our community. And then I think, it's really quite significant for us, particularly those in mental health services. Now, we would go quickly to MP Chi Omura to sort of educate us about the government's approach. Thank you.
Thank you very much. Thank you very much. First of all, just thank you very much for inviting me today. I'm honoured to be in such impressive company. And I was listening very closely to Dr. Ojo's opening comments. And I'm very pleased to hear the work that you're doing on the impact of COVID on mental health. I'm also very pleased to the way in which the Association of Black Psychiatrists is addressing this incredibly important subject, which hasn't been considered and haven't been given the prominence it needs to be. So yes, I'm the Labour MP for Newcastle upon Tyne Central. So as a Labour MP, I'm in the opposition to the government, but I will share with you my thoughts and some of my fears with regard to how the government is handling the COVID crisis, particularly in regard to Black communities. I'm also the Shadow Digital Science and Technology Minister, and I am the chair of the All-Party Parliamentary Group for Africa, and we have done some work looking at some of the stigma, unfortunately, that still remains with regards to mental health in African countries and in African communities, in the African diaspora. But I want to start by emphasizing and supporting what Dr. Ojo was saying about the impact on BAME communities, and start, if you like, the way in which the virus continues to expose the deep-rooted structural inequalities in our society, and these drive health inequalities. And I want us to pay tribute to all the Black and minority ethnic people whose deaths could have been avoided during this pandemic. And we need action to address the hugely disproportionate impact that coronavirus is having on Black, Asian, and minority ethnic communities right now. And the government have so far failed to implement many of Public Health England's recommendation, so that the countless families who have lost loved ones and their communities should not have to wait any longer. And that's why Labour has set out the need for a race equality strategy that takes lessons from the COVID-19 virus pandemic and seeks fundamentally to change the systems and institutions in which these structural racial inequalities exist. So in October last year, the Institute for Public Policy Research and the Runnymede Trust showed that well over 2,000 Black and South Asian deaths could have been avoided during the first wave of the pandemic. The government must be prepared to admit and act on the root causes of the hugely disproportionate impact that coronavirus has had on our Black and ethnic minority communities. And yet when I asked the Women and Equalities Minister, Kemi Badichuk, about the reasons why BAME citizens are disproportionately impacted, Her responses were evasive and cooperative, and she continues to deny the existence of structural racial inequalities as a factor in the disproportionate impact on BAME communities of COVID-19. Last summer, my honourable friend, Dawn Butler, the member for Brent Central, called a debate on the impact of COVID-19 on BAME communities. And in that debate, she raised the structural racism, stating, that being Black is a pre-existing condition that results in worse outcomes for health, employment, and education. And the Institute for Fiscal Studies agrees, saying that BAME citizens are 49% more likely to die from COVID-19. And the ONS have said that BAME communities are hit by a COVID triple whammy, with income, life expectancy, and mental health all disproportionately impacted. And we've heard some of that. So last June, the Health and Social Care Secretary said that the government would consider Black, Asian, and minority ethnic groups as a priority for the vaccine. However, this has failed to be the case. Vaccine take-up amongst BAME communities is now shown to be worryingly low. So among those aged 70 to 79 who have been receiving the jab from mid-January, white people were most likely to have been vaccinated. 86% jabbed by 11th of February, as against only 55% of Black 70 to 79-year-olds, 68% of people with mixed heritage, and 73% from South Asian backgrounds. So the BBC have said that ethnicity is the most significant factor in someone's likelihood of taking the vaccine. And this is deeply concerning. And the government must address it as soon as possible to ensure the UK's health inequalities are not further entrenched. And so, this month, together with MPs, members of Parliament from across the House, we took part in a video to encourage people of BAME backgrounds to get vaccinated and beat the virus. And you might have seen that was promoted by the Minister for the Vaccines, Nadeem Zahawi. I think whatever our political differences, we all come together on supporting, encouraging the take-up of the vaccine, and particularly encouraging communications with BAME communities. We need government to put the safety of those most at risk ahead consistently throughout the pandemic. And we need all our communities to get vaccinated. Only through vaccination can we make life safer for ourselves and our communities. And the vaccine has been rigorously tested for safety and effectiveness, and has been approved by independent regulator, the MHRA. Across the world, people are desperate to be vaccinated, and we've seen that there are already concerns about inequitable access to vaccine. So it's vital that we don't let misinformation and mistrust put people's lives at risk. And what the research shows is that BAME communities in particular are more likely to take the vaccine when you've got access to clear communication, but also through trusted routes, through trusted people and trusted places. And so that's why it's so important that respected and trusted leaders or role models in our communities promote and encourage the take-up of the vaccine. And I'm pleased to see campaigners such as Denise Lewis, Ramesh Ranganathan, and David Olusogun, who have joined together with others in promoting and encouraging BAME communities to get vaccinated. And I'm also continuously campaigning against the misinformation that still can be found on social media sites such as Facebook and Twitter. Now, just finally, I want to talk a little bit about the impact that COVID-19 is having on BAME mental health, because unfortunately, and that's why I'm so pleased to be invited to speak today, very little has been said about that. Mental health charity Mind have found that the structural inequalities in our society have had a direct impact on the mental health of BAME citizens. who are more likely than those who identified as white to need advice and to help manage their mental health. During the first month of the pandemic, a third of people from black backgrounds reported struggling to make ends meet in comparison to just 10% of those from white backgrounds. And almost 1 in 3 BAME people said problems with housing made their mental health worse during the pandemic compared to 1 in 4 white people. So this is particularly concerning. As Dr. Ojo said, referrals to mental health services dropped during the same period, but it's particularly concerning because of existing inequalities in access to physical and mental health services. So it's entrenched inequalities in mental health treatment and access to services have existed for many years, but they've undoubtedly been deepened during the pandemic. And so the disproportionate impact has put BAME communities at greater risk of developing mental health problems. And this, as Dr. Ojo indicated, historical racism and experiences of inappropriate support have left many individuals from BAME communities distrustful of mainstream health services, highlighting the need for support for the community. And that's against the background that in 2019 to 2020, the rates of detention in England under the Mental Health Act were more than 4 times higher for Black or Black British people than for white people. And I think that's a statistic which should be a huge cause for concern at any time, and particularly that now when we consider the impact that has on the appropriateness of mental health services, or existing mental health services for Black and minority ethnic communities. And we know that a review by the British Medical Journal found that even before the pandemic, ethnic minority patients receive worse mental health care than white patients, with lower levels of prevalence and access to services in their communities. And we see circulating on social media concerns by Black and minority ethnic patients and their loved ones about the level of service and support that they will receive, both for COVID treatment and also for mental health treatment. So I think people, the pandemic has had a terrible impact on almost every aspect of our society, almost every aspect of our economy, and the NHS and we're so lucky to have the support of our National Health Service at this critical time. But we do need to assess and look at the ongoing disproportionate impact on BAME communities and BAME mental health, and the disproportionately low take-up of vaccine amongst BAME communities and the connections there. It has a real impact on the lives of so many people in our country. Labour is calling strongly for analysis, for investigation, for appropriate data collection. That's one of the issues that we have, is that we're not collecting always the data on ethnic communities as in terms of treatment, in terms of the impact of COVID-19, and in terms of vaccine delivery. So as part of this terrible pandemic, we are none of us safe. We are none of us protected until we are all of us protected, and we are all of us safe. And that applies globally, and it applies in the UK, and we must work together to ensure that the existing and disproportionate inequalities in our health and mental and physical health are not entrenched and exacerbated as part of this terrible pandemic. Thank you very much.
Thank you, MPG, for that. And I think the key message for us to take away is to sort of ensure that we get information that we trust. And I'm sure you're holding the government to task to ensure that they're making use of the best evidence and looking at the data. Thank you very much. Can I ask if there are any questions, if it could be directed to the chat box? Thank you for attending. I know you need to leave early, but there may be a few questions if possible.
I can see there is a question asking if there's going to be an inquiry into the government's handling of the pandemic. And just to say on that, I think there's going to be a number of inquiries. I'm very, very, I think it's very important. This has been such a wide, it's such a devastating impact in so many aspects of our lives, as I said, and I think there will be a number of inquiries, and the sort of the question is when and how they are held, and I think an inquiry into the impact on BAME communities specifically, and the fact that we haven't got it's highlighted the lack of data, it highlighted the lack of existing consideration of some of these structural inequalities, and I do think that's important.
Thank you. We would now have our clinician from the front line telling us exactly how it is. Dr. Chimaoti.
Yeah, thanks very much, and thanks for inviting me. Thanks, my fellow panelists, Tim and Chi. Fantastic speeches there. So I'm here to talk about the different aspects. I'm here to talk about the fact that I work in, I'm a consultant in anesthesia and critical care. And as some of you would know, one of the main problems then, if you remember in March, was things like discussions about the ventilator. If you remember the ventilator, when the government was saying they're going to get ventilators from around the world, so people were worried about that. So I'm here to tell you about how it was for somebody who was actually in the hospital having to deal with these patients. So my story dates back to March, the week starting commencing March the 9th of 2020, when we hit the hospitals and patients were coming in hypoxic. So they were coming in essentially, and their oxygen saturation levels were really low. And I happened to be on call on the weekend of the 13th, 14th of March, I believe it is. And that was my first time of coming in contact with a patient that had COVID. How did they present? They came in very breathless. They came in, breathing really in distress. And because we're not sure we're dealing with, we had sort of put together a quick program of how to protect ourselves with PPE and everything. And on that Saturday, I remember very well going in to see my first patient, and I was quite scared, and rightfully I should have been scared, because the patients were put into rooms, and you're not allowed to go into the room, and we had to communicate with the people outside with everything that we wanted. And I was asked to intubate this patient and put them on the ventilator. Now, if anybody would think about what they're asking me to do, they're asking me to go into a patient who is breathing this virus into the air, put my face in front of him, and take him into a machine. That's just to put it in lay terms. But somebody has to do it. And on that day I was on call and I did it. And that was the first of many. And then the following week, my hospital, London Northwest, was the first hospital in England to declare a critical incident because we were running out of beds. I cannot describe for many purposes what we saw, but to put it in summary, at that point in time, I remember the following week I was about to go home at 5 o'clock. We couldn't go home because people were just going to get patients from the emergency department to put them on all sorts of ventilators. We had makeshift ITUs created, and it was nothing short of depressing. But we carried on, and obviously we stopped elective surgery, and we expanded, and I'm sure most of you have seen a lot of stuff, because what has happened now in the second wave is that the government has now allowed essentially cameras into, so I'm sure many people have seen how the intensive cares are. It was very, very difficult. It was depressing, and it's something that we thought would not happen again. Now let's fast forward to June. June, what happened? June saw the first the recovery trial, which was held in Oxford, and essentially they discovered that dexamethasone was the first drug to actually have an effect on mortality of COVID patients, even though it was for those who were severely were really sick and those that were requiring oxygen or the ventilator. So when we now got that, that was the first drug. The same recovery trial group, they've tested so many drugs, and until date, I think it's just one of the monoclonal antibodies which has also been shown to reduce mortality. So what it says is that all the other drugs that we've been trialing, like chloroquine and remdesivir, the two drugs that we know for sure, randomized control trials, are dexamethasone, which thank God it's cheap, and therefore it's available in all sorts of, in all over the world. And then the monoclonal antibody, which is a bit more expensive. Remdesivir also has been used. Now comes the second wave. And when the second wave comes, people are thinking, like some of my panelists have already mentioned, they first started off by saying, oh, it's not affecting Black people more, we're immune. And then all of a sudden, the statistics start to show that actually we were high risk. But unfortunately, people were dying, healthcare workers were dying. And if you look at the beginning of a lot of the healthcare workers that died were healthcare workers who had proximity with patients that, obviously the viral transmission, like some of our ENT colleagues, Max Fat colleagues, dentists, and eventually it took a while for people to understand, oh my God, this is what is going on. And when the second wave came out, you would think that people would be more aware, but unfortunately, in just that trend, death started to rise again. But thank God, medicine is better, critical care is better. We're better. We now started to find out that delay in dexamethasone is here now. Delay in ventilation, so we leave them on non-invasive ventilation, which is one where you see the mask on the face, but they don't actually fall asleep. We lie them on their tummies, and we started this, and actually we found out that was actually helpful. But it didn't change the fact that, unfortunately, people from the ethnic minorities, like the Black minorities, and people with certain comorbidities were still at higher risk. That hasn't changed, and the ONS continues to publish data that shows that, unfortunately, people from the Black and ethnic minorities are still at higher risk. So it is real. Now, I'm going to fast forward to what we're doing now. So I was asked to write an article for my trust. And why? Because they found out that when the vaccine came out, then everyone goes about lots of questions, and understandably so, and lots of and lots of hesitancy, and that's fine. But what I'll try to tell people is this: that the second wave doesn't have to be like the first wave, because for those who still have doubts that this disease exists, I almost wish that I could. Well, this is why I'm here. I'm trying to tell them that it does exist, and you don't know how your body will respond to this disease. Some people will get the fever, some people will stay at home, but some people will come to us in intensive care. And I remember going to I remember speaking to somebody in between the two surges of COVID, and the person said to me, oh, I think it was my barber, the guy the barbing salon, saying it doesn't exist. And I remember clearly on the 15th of January when I met a young man in intensive care. So as you know, what we do these days in intensive care, we have to prone the patient. So we change, we turn them from one side to the other to improve their oxygen delivery. And there was this young man, and I remember the day, and he was younger than me, and he was slim, and he had no comorbidities. And he they told me to come and change his position. I said, look, I'm just going to pop in and pick something up. And by the time I came back, he was dead. And I saw this guy, and he had an African name, and we had to call the family. And obviously, in intensive care, you're not allowed to see your relatives at all. So essentially, all you receive is a phone call. And from that day, I decided, you know what, I'm going to start to tell people that, I'm going to have to tell people that this thing is real. Because I could just imagine that being somebody like my barber or someone that I knew. And that's what drove me to tell people that, to take the vaccine myself and to start telling people about the vaccine. And I sort of summarize it into 3 points. People ask me all the time, well, there are lots of questions, and we're addressing that every day. Why do you take the vaccine? I said, well, there's 3 main reasons. One is that I don't want to die, because COVID kills people. And if I don't have any, I'm not paid by anybody to make this speech. I'm not getting anything for this. This is just me saying that COVID it kills people. And if it doesn't kill people, there is the fear of what we call long COVID. Long COVID is where we're having symptoms that we don't even know. There was talk yesterday, one of the professors of King's College London, looking at long COVID. Some people that used to run a marathon, they can't barely walk the stairs. How do you know? If you saw the CT findings of a COVID lung, anyone could see the difference between a normal lung and the CT lung. This disease is real. The third one is transmission. you know, when I saw the fact that in the second wave, there were some children, there was the one I saw, yes, he had comorbidities, but he actually had COVID. And I started to ask myself, what will I do if it turns out that I came back from work one day and gave my own child COVID? So everybody has a tipping point, and the experience that we have in critical care from the front line, where essentially what it is that I am knowingly going to meet these patients. Because somebody has to do it. Somebody has to be with them. Somebody has to look after them. And I am knowingly going into intensive care, you know, or the wards to go and meet these patients. It's almost like, I mean, I put it, I can't find it. It's like going to war. You know that the enemy is out there, but you have to go. So my role is to prepare myself, you know, which is what I'm doing with the PPE and the vaccine. And my role is to tell people. So if you go to war, you tell the people back home that there is a war out there. You all don't need to come to the front line. You need to avoid coming to the front line. And that is the role that people like us in critical care have. And that's why I'm very happy that the government has started to allow cameras into intensive care, because people need to know that, please, you can debate from now to whenever about whether the vaccine is right for you or why it's not affecting, whether COVID is real. And I'm telling you that we don't know, yeah? But what we do know is that 3 things, and I'll summarize them again. 1, COVID kills and has killed people. It puts people in intensive care. The people, the average, you know, there's an average length of time of a COVID patient from when they come into intensive care to when they leave. And the number is good. Some of them stay weeks on intensive care because they go from the ventilator to the kidney machine to everything else. 2 is that there is long COVID. Even if you survive the effects of COVID, you have no idea what it's going to do to your system and your long-term care. And for all those who don't know, people who are having elective surgery, there is already in your consent form, there's already an increased mortality rate associated with COVID, which we all have to tell you about. And finally, is transmission. You don't know who you're going to transmit to. And that in a nutshell is my experience from the front line. Of course, I could, I mean, you know, in later on, I could answer more questions, but in a little 10-minute summary, I'm here to say, COVID is real. I lived through it. I had to go to work. We didn't have a choice. I didn't have the luxury of staying at home to decide whether to go. We had to step up. We had to all become critical care doctors. I'm there next Friday. I'm there tomorrow. I live this every day, day in, day out. And I just want to let people know that it is not a good disease at all. It is very dangerous, and it's not the same as any of the other diseases that we've seen. But I'm so glad that we've got this far. Thank you so much.
Thank you, Dr. Oti. And I think in summary, what he's saying is, this is real. This is real. Protect yourself with the vaccine and your family. Now we'll go very quickly to Reverend Bao.
Yes, good morning, everyone. And thank you so much to the Association of Black Psychiatrists for inviting me and for the speakers who've gone before. In my 10 minutes, I want to talk about COVID and faith. Would God want me to take the vaccine? And so I'm going to, if you can enable me to share my screen, then I would share with you. If the host can enable me to share my screen, I thought you said it would be shareable. So let me just, first of all, say that COVID is real. It does affect people and it doesn't kill people. Secondly, what COVID has done as well is enabled me to see so many people who look like me, who are doctors and professors and you know, really looking out for their communities and doing great stuff. I still can't share my, oh, here we go. Let me share my screen and then I will, actually talk a little bit about what I've prepared to show us here. Okay, let me share that. Okay, so I want to talk about, does God want me to take the COVID vaccine? Okay, now there are obviously historical reasons why there is hesitancy amongst the Black community. So I'm just going to look at the reason that I'm going to look at the the various religions and also Christianity's response to vaccine and medicine in general, and then end up with a conclusion. So in my 10 minutes, I hopefully will take you on a journey which, tells us about the faith response to medicine in general and the vaccine in particular. So just quickly, there is medical racism. We know this. We know about the 1932 Tuskegee syphilis experiment when 140 Black men died. They were actually, tricked into taking syphilis, even though there was a cure. We know about the 1992 fenfluramine studies when Black and Hispanic children were given a diuretic to see if it would actually stop them from becoming criminals. We also know that in 2014, there was a tetanus vaccine in Kenya, and the Catholic bishops there came out against that, saying that they're trying to sterilize Kenyan women. And also in 2019, a couple of years ago, a polio outbreak in African countries, about 5 African countries and Asian countries. And we also know that Black women are 5 times more likely to die during childbirth compared to their white counterpart. These are facts. So there is medical racism. And so what about religions and vaccination? Well, the majority of religions have no prohibitions against vaccination. However, there are 3 reasons why they would mitigate against these. There are reasons in general. There's also theological reasons, and there's also specific objections. The ingredients, what's inside the vaccine. In terms of Christianity and the various Christian denominations, most Christian denominations have no scriptural or canonical objections to the use of vaccines. These include the Roman Catholic Church, the Eastern Orthodox, the Oriental Orthodox churches, Amish, the Anglican Baptists, and so on and so forth. There are, though, some denominations who do, or some of the members of some denominations who do have objections. For example, the Dutch Reformed Church. They have restrictions. They have, thoughts about not taking it. However, within those same groups, some of their members see the vaccines or medicines as a gift from God. And then there's the faith healing denominations, for example, like the Faith Tabernacle, Faith Assembly, End Time Ministries, who believe, and also the Church of Christ Scientists, who believe that, focused prayer would help to prevent certain diseases. And so what about ethics? The most morally questionable issue regarding vaccination is using cell lines derived from a voluntary aborted fetus. And so in Australia, we had the Catholic Archbishop of Sydney, the Anglican Archbishop, and also the Greek Orthodox Archbishop writing to the PM, warning him that people would not take the vaccine if it contained aborted cell lines relating to a baby nearly 40 years ago. However, in the case that there aren't any alternative, they would actually tell their members to take the vaccine. So in terms of our theology, the Bible does not specifically speak about vaccine. However, there are 3 general guidelines about caring for the sick. The human body cannot be treated apart from the soul, as it said in scripture. And so we are, even though we're talking about a physical vaccine, we've got to think about how this pandemic has affected the psyche, the soul, and, we're talking about getting a jab in the arm. What we've got to think about is having a jab in the soul. How will we would deal with the anxiety, the stress, the depression, the various mental health fallout that comes from lockdown and other things like that. And secondly, in the Bible, in our theology, there is the basis of hospitality, which is a fundamental motive driving clinicians and those in hospital to actually look after those who are not so well among us. And thirdly, we see medicine as a divine gift from God, as it says in Psalm 147, verse 3. And so in summary, we, within the Christian creation, fall, redemption, restoration framework, immunization advocacy can form the basis for Christian service to humanity. This is consistent with the theme of we are our brothers and sisters' keeper, and also loving our neighbors as we love ourselves, and also acting kindly to strangers like the Good Samaritan, as we find in that story in Luke 10, verse 35. Christians have historically supported immunizations. However, a few denominations have objected on spiritual or ethical grounds. And we know that immunizations and vaccines are placed within the tradition of hospitality, i.e. care for the soul, which is fundamental to our Christian faith. And in the Christian tradition, health is never separate from spirituality. And holistically, we care for the whole person. And we, particularly us from the African Caribbean diaspora, and also us from the majority continent of Africa, we embrace the term, the notion of Ubuntu, where we just don't look after just the physicality, we look after the whole person. And therefore, if I'm affected, you're affected. And if you're affected, I'm affected. And so I just want to encourage those of us who are listening here that the COVID-19 pandemic is real, and it affects Black and Asian people disproportionately because of historical antecedents, because of systemic racism. However, you know, there's been now about 19 million or 17, 18 million people being vaccinated already in the country. Last Friday, there was about 58,000 Black Londoners who've taken the vaccine. And I would say, does God want me to take the vaccine? God wants me to be well in my physicality as well as in my soul. And God, I see vaccine or this vaccine as a gift from God for us as Black people, so that we can actually not just thrive, but be able to tell our stories and help our communities who are suffering. And we are suffering as a people disproportionately. And that is the end of my 10 minutes. Thank you so much. Bless you.
Thank you, Reverend Bell. And I think what I've taken out of that, the key message there, immunization and vaccination are placed within the tradition of hospitality. That's really powerful. And that is the core of Christianity. Thank you. We'll just move on quickly to our next speaker, Dr. Okonkwo, our GP lead.
Hi everyone. Thank you so much for such an interesting seminar and all the things that we are learning. My name is Dr. Oni Okonkwo. I am a GP in Birmingham at the One Medical Center, and I am also the clinical lead for the Black Asian Minority Ethnic Networks for Birmingham and Solihull CCG for the primary care aspect. And I'm also co-chair at the moment for West Midlands Region, the BME, the BAME group of the BME. So I was asked to speak to you about what is going on in the community in terms of the vaccine. We have been doing a lot. In addition to our day jobs, we are having to vaccinate the whole country, and that has been quite a feat. So we started the program on the 8th of December, and initially it was just the hospitals that were stood up. But within a week, we brought it into what we call the GP hubs. Now, what happened was about 2 years ago, they decided to put GPs into groupings based on our patients. So 30,000 patients of maybe 2 or 3 GP surgeries or more would make up a hub. So within a week, we started vaccinating patients at the hubs. Then at the beginning of this year, we added what we call the mass vaccination sites. For those of you in Birmingham, that would be the Millennium Point. And these are sites that people that live within 45 minutes of that particular location could register and have their vaccinations done there. And we also added pharmacists as well to the mix. So at the moment, we have 267 hospital hubs. We have 1,034 local hubs, which is a combination of GP hubs. Some are done in the mosques and temples and churches, and even mobile units for vaccinating people. And we have 192 community pharmacists actually offering the vaccine to patients, and 102 vaccination centers all across the country. So you can see we are trying really hard to get this vaccine to as many people as possible. And like I said, some areas have now started taking mobile units to various areas to make sure that as many people as possible are vaccinated. Now, what are we using? We started off with the Pfizer-BioNTech vaccine, which was the one I'm sure a lot of people heard about, that you had to store at -70. And the moment it was taken out of the freezer and transported to us, we had 3.5 days to get it into as many people as possible, minimum of 975 patients. But early this year, the AZ vaccine, the AstraZeneca Oxford vaccine came on board as well. And I have to say that has completely been a big game changer for us, because not only are we now able to offer it in hubs, when we realize that patients are having problems accessing these hubs, we've now been able to transport the AZ vaccines to individual GP practices so that the patients can go there and have them. And that is also what we are using in most of the mobile units. So when it came on board, that absolutely increased the number of people we could vaccinate. So far, we've managed to vaccinate, according to the government figures, although they've said in the last few days it's been more, we've done at least 13 million doses. I know people have been asking about why are we doing the first dose and why are we doing the second dose? So far, we've done at least 12 million of the first doses. And the reason is that if you actually look at the evidence, I think half bread is better than none. If we're aiming like Pfizer-BioNTech, the full dose gives you 95%, but if you have the first one, it gives you 84%. It would be a good idea if you had 84% fighting chance than have a 0% fighting chance. So we are at the moment trying to get it into as many people as possible for their first dose. Who are we vaccinating? We are vaccinating cohorts 1 to 6 at the moment. Cohort 1 was all the people in care homes and all their carers. Cohort 2 was all the people that were 80 and over, and also people like the doctors, the frontline workers, the social care workers. Cohort 3 was all those over 75. Cohort 4, those over 70, and those we class as clinically extremely vulnerable. These are people that have things like cancers and things like chronic lung diseases. We thought we had got this first 4 group under control, but last week, the government reclassified those that were clinically extremely vulnerable. So patients that were not originally on the shielding list, about 1.7 million of them were added on the shielding list. For my practice in Birmingham, that was actually quite significant, because we suddenly went from having 13 patients waiting to be vaccinated in cohort 4 to 290. And rightfully so, because we need to protect those most vulnerable amongst our community. And now we've gone to cohort 5 and cohort 6. But cohort 5, we're asking to be done in most of the mass vaccination centers so that we can focus on cohort 6, because cohort 6 are all those people who are eligible every year for a flu vaccination, of which you have those that are 16 years and over with things like asthma, things like COPD, chronic lung problems. And we come to what do we want people to do? At the moment, we're asking you to please spread the message, not the virus. If you look at how many people we vaccinated, The census in 2011 said that we have about 9.8 million white British, and we have 212,000 odd Black people. So there's about 86% to 3% Black. But if you look at the vaccination figures, we are lagging behind. The Black, Asian, minority ethnic group, we are really lagging behind. And you've heard all the reasons. People have tried to explain the reason. And all we are asking you is, each and every one of us, as individuals in this country, we need to make an informed choice. Please try to get the right information. Forget about all the misinformation you're listening to. Go to reputable sites, get the information, inform yourself so that you can inform others and make nobody's forcing anyone. We're not saying you must have to have it. It's not for everyone, but please don't make decisions based on what people are saying. Rather, make decisions based on the facts. We are hoping that by middle of May, or that is the government's target, that we would have vaccinated what we call, according to the JCVI, the top 9 classifications, which is all those over 50 and those that have comorbidities. We are getting there. We're not very far off, but we need help, especially as ethnic minority groups, so that we are at the same time protected as much as all the rest of the communities in this country. Thank you.
Thank you. Thank you, Dr. Kunhwo. I think the message there is, please work with your GPs, protect yourself, protect others. We just move straight to the next speaker. We will have lots of questions. Keep sending your questions into the chat box and into the Q&A panel. Thank you. We've got Sheikh Nuru Mohammed next.
Thank you. Good morning, my dear brothers and sisters, and thanks to the Association of Black Psychiatrists for organizing such a timely seminar. It has so far been very informative, and I've learned a lot from my fellow panelists. I am Sheikh Nur Mohammed, the resident Minister of Religion at Al Abbas Islamic Center, the first mosque to be converted into vaccination hub in the entire UK. And I'm proud to be the Minister of Religion at this mosque. I'm also a member of the West Midlands Combined Authority Faith Strategic Group, and I doubled as the co-chair of the Birmingham Citizens UK chapter and also the trustee of Citizens UK nationally. It is always refreshing to hear our own medical experts discuss both physical and mental health. Glorious Quran, chapter 23, verse 12, teaches us that we human beings are made up of 2 major components, the physical and non-physical. Physical has to do with our physical health, and non-physical has to do with our mental health. In other words, glorious Quran recognizes both physical and mental health, and that there is a reality to this, and we have to take it seriously. The question at stake is that, would God Almighty want me to take the vaccine? This is a very important or fundamental question. And this question, no doubt, leads to another very important question, which is, what is the purpose of going for the vaccination when I'm invited by the NHS? The simple answer is that this vaccine is the only effective way to reduce death and severe illness from COVID-19. Glorious Quran attached significance to sanctity of life. To such an extent, God Almighty in Quran 5, verse 32 says, and I quote, "Whoever saves one life, it is as if he saves all of humanity." This verse invites us to appreciate and recognize the importance of saving life. Central to what we do as people of faith, as Muslims, is service to God and service to humanity. Servitude, my dear brothers and sisters, is dependent solely on our medical status. When I'm physically and mentally fit and go to pray and I stand there or I kneel down, the level of my concentration will be unbelievable. But if I'm not that well, there might be concentration, but it will not be to that level. Hence, glorious Quran, when describing the qualities of believers, mentions one quality which has to do with what we are discussing today, that believers are those who keep to their promises and trust. The Holy Prophet of Islam, Prophet Muhammad, may the blessings of God be on him and his purified family, was asked, what are these trusts that God Almighty is talking about in glorious Quran? Prophet began to explain, and one of the examples of trust which was mentioned by our beloved Prophet is taking care of one's health. In other words, taking care of our health is something that is cherished by Almighty God and sanctioned by glorious Quran. Health is God's trust to us. And when we are entrusted with something, what is expected of us is to ensure that we take care of the trust and maintain it the way it was given to us. So a true believer from the teachings of Quran is someone who is passionate when it comes to taking care of his or her health. Again, when we go to Quran 23 verse 8, God reminds us that taking care of your health is no doubt keeping the trust between you and Almighty God. Quran 28 verse 77 also teaches us that we should not forget and forsake our shares of this world. Each and every one of us has some shares to claim and benefit from while living in this world. Quran says, and I quote, وَلَا تَنْسَ نَصِيبَكَ مِنَ الدُّنْيَا. Do not forsake your share in this world. The Holy Prophet of Islam, when giving the commentary of this beautiful verse, you know what he said? He said, one of your shares in this world is taking care of your health. Health is wealth. Health is precious. Whatever we do in life is solely dependent on our health. So it is logically and religiously important for I and you to take care of our health. And no doubt, Quran 102 verse 8 tells us that one of those things that will be questioned about on the day of judgment is how we take care of our health. That on that day, you'll be questioned of the blessings bestowed on you by Almighty God. The Holy Prophet of Islam mentioned one of those blessings is the health that we have. And hence, scholars based on the teachings of Quran and Prophet Muhammad, peace be upon him and his blessed family, said that there are two hidden blessings in the life of each and every individual. But people often do not pay attention to these blessings when those blessings are there in their lives. They tend to look for those blessings when they are no more. Scholars mention they are peace of mind and health. Peace is crucial. We can't do anything without peace. Likewise, health is crucial, as I mentioned earlier on. So this vaccine, my dear brothers and sisters, is our way of going back to some form of normality. But not only that, it's a way of taking care of that trust which is given to us by Almighty God. I have had my first jab because of the type of work I do with vulnerable people. And I must say, my dear brothers and sisters, it's simple and safe, and it will save life. In conclusion, going for this jab is nothing but reinforcing the sanctity of life. So let us go for it and do not hesitate. When you are in doubt, reach out to those GPs that we have trusted for many years. The same GPs are telling us, go for it. And I hope and pray we'll all join our hands together in fight against this COVID-19. Thank you for having me. May God bless you and make it easy for all.
Thank you, Sheikh Mohammed, for that inspiring talk. The glorious Quran supports the sanctity of life. So it's our responsibility to ensure that we remain well. Thank you. That was powerful. I hope you would stay back for some questions. Without much further ado, Professor Anthony Manuel.
Thank you very much indeed. Thanks for the invitation to participate in this brilliant session. Thanks for allowing me to speak alongside the brilliant people who have spoken before me. And it's just the best thing to be surrounded by other Black and Asian people around us at this kind of time. I must say, it's one of the few silver linings to this kind of pretty miserable 1 year that we've all endured, is seeing and having a profile to BAME people, not just to be the kind of the stereotypic victims of society, albeit we still have a long way to go with that. And I want to try and touch on some of that as I answer 3 areas that I've been invited to participate in. So I'm a background as a clinician, and I carry on doing some work as a pair of hands, incompetent but well-intentioned pair of hands on the ICU. I present, however, today not so much from that perspective, but as from the perspective of the fact that I am just taken over as the lead for the workforce race equality strategy at NHS Improvement, and with a mission to try and deliver change rather than talk about data. And alongside that, this kind of engagement is incredibly important. So thanks for the invitation. So the 3 questions I was going to try and address. Number 2 around the vaccine. How was the MHRA that you heard about able to approve the vaccine quickly? What is the technology on which the vaccine is based? And why should people from our communities take the vaccine? So about the MHRA approval, the MHRA, as you heard from the MP, is an independent organization. It doesn't have any ties to the government. And similarly, the JCVI, the Joint Committee on Vaccination and Immunity, is also an independent, scientifically based community. And the MHRA credits the rapid turnaround due to its so-called rolling review process, which allowed it to analyze the data as they were being submitted. So rather than getting a dossier, a portfolio of information, and then going through it all at the end, they took a very different approach because of the global nature of the pandemic, which you will all know about and have heard about eloquently in some of the previous talks. So that data included results from the laboratory and clinical trials in humans. It also included data about the manufacturing processes and the contents that you've also heard about, the quality control processes that go through any vaccine or any drug production, the sampling of products and how that is done for quality control, the testing of the final product. And the processes were run in parallel. So rather than being run in sequence like normal, which takes decades or decade at least, they were run in parallel with the compensation being offered, as you probably heard about from Trump and from our government, to mitigate any costs lost that were met by these companies if they hadn't panned out. Now, there's an ethical question about whether that was doable or right, but it was the guarantee that was made, allowing all these processes to be put forward at one time rather than waiting to go through one filter after the other. And the MHRA agreed that the vaccine data met or expected or exceeded the high standards of safety and quality and effectiveness, and that the trial size was equivalent to any of the previous vaccine studies. This approach was aided by the speed at which scientists in China identified and shared the information about the genetic sequence of the new virus. That was an incredibly important first step. And in all the kind of racist talk about China, China, we must remember that their scientists were at the vanguard of this and shared this incredibly willingly and at pace, such that the work that had already been done in other coronaviruses was able to be adapted very rapidly. And finally, the other reason the mRNA were able to prove quickly was the advances in technology have streamlined data recording, and the advent of social media has made it easier to recruit trial participants. And so actually a lot of things combine to allow us to get this process allied, of course, the great public desire to help, where we were able to get approval quickly. So the second question then, what is it about mRNA vaccines? I say this as a non-immunologist, but somebody's done a good deal of reading. So this is me distilling other people's knowledge, standing on their shoulders. The vaccines were developed using different so-called platform technologies to what we are used to. They involve slotting genetic material from the virus into a tried and tested delivery package. So we've had vaccines giving immunity or provoking immunity through these standard packages. But what was different was this ability to use genetic material. And so once introduced into the human body, this genetic material from the virus, modified so it can't give you an illness, then makes the protein making machinery in our cells start churning out the spike protein part of the coronavirus. So it doesn't actually make the bug, but it makes the part that allows our body to then target an immune response to that part of the organism, which is the part that seems to be responsible for getting into our bloodstream and then into our immune system beyond that. And therefore, the particular data you've seen is not only does it prevent infection, but to a greater extent, it prevents the severity of infection and need for hospitalizations and so on, and the deaths. But while such platform technologies are a non-traditional approach, that doesn't mean that they aren't tested. It's important to understand this. The mRNA vaccine technology has been in development for over 2 decades, since the turn of the century. And the use of these technologies not only means a vaccine can be rapidly developed, but that it also has a good safety profile from the start. And of course, other aspects of it are important. That the production is faster, production is cheaper, since they can already piggyback on existing production processes. So that's the thing about the mRNA vaccines and why they've been of such potential promise for us, not just now, but also going forward. And the final question is, why should people from our communities take the vaccine? Well, the first thing about that is to look at the safety question. Is it safe for us to take these vaccines? Well, if you look at the studies done in North America, 42% of the global participants and 30% of the US participants were from racially and ethnically diverse backgrounds. So this is not untested in our people. So that's the first thing. Secondly, as has been said by the 2 ministers of faith, part of the action we can take as citizens to return to normal is to vaccinate, and there's a societal duty to that. It is not the only thing we do. It may be the best or most effective thing we do in terms of evidence, but we must also remember that we also need to do the thing about washing our hands critically. We need to preserve physical distancing. We need to cover our faces. We need to do all of those things. Another aspect of safety is that we've now delivered, last count at on Thursday, last 128 million doses have been delivered globally, and about 14 and a bit million in the UK. And what we're now seeing is data of falling incidence and falling mortality in the vaccinated population. So if you look at the over 80s in the UK, we're seeing for the first time their numbers are falling faster than they've ever done before this. And almost every complication that is going to show up with this in terms of safety, with any shows up within 2 weeks. And now with 128 million doses given, we're not seeing that other than mild side effects. The final thing, reason that I think is really important that we vaccinate, apart from all the things you've heard, is that there's going to be this epidemic of long COVID. You talk about the psychological and psychiatric effects that we're likely to see. This whole physical and emotional complication of long COVID is going to disproportionately affect BME people for all the reasons we know about. And it's better to get vaccine immunity than the risk of getting infected and getting post-infectious immunity. The vaccine doesn't give you long COVID. Getting COVID can give you long COVID. So I think we need to agitate and ask and do our best we can as health professionals to work on a long-term strategy for Black health. That is an incredibly important thing, and BME health. But the vaccine is one part of this. We mustn't say, yeah, we demand your trust, you must give us trust. We have no grounds to demand that. What we can do is to beseech and make the vaccine the first thing we do if we have any integrity about this, to say we're going to tackle the other aspects of why BME people experience worse health outcomes in our society. Thank you very much indeed for inviting me to participate. I look forward to hearing all and any questions you have, and I'll do my very best to answer. Thank you.
Thank you, Professor Emmanuel, for that. And I think the message is clear there. The vaccine is safe, and they were highly encouraged to take it. We go to our councillor, Patsy Cummings, please.
Thank you, and thank you for inviting me to be part of this amazing panel. There's been a lot of different health professionals that have actually rallied together. I've been on a number of, attended a number of panels such as this, and been on a couple. And it's great to see so many of our community rallying together to give information, to provide people as much information so they can make informed choices. So I'm Patsy Cummings, I'm a counsellor in Croydon, and what I'm probably most proudest of being is the BAME, I'm not going to say the word, the Black and Asian Minority Ethnic Champion for the whole borough. And what that means for me is that I try to champion equality, diversity across the whole of our borough, because we need to recognise, and all of our counterparts need to recognise that we still need to do a lot of work to tackle systemic racism in every single facet of our community. And obviously the COVID virus highlighted it to all of us. So I'm going to be really quick, because I'm keen that you hear from your professionals, healthcare professionals here, more than me. And obviously there is a lot of time for Q&A. So Dr. Anton's also mentioned it, but a question for me was, how was the vaccine done so fast, and is it safe? I was on a platform with Dr. Donald Palmer and Dr. Wayne Mitchell, two scientists who are very similar to the people that you're listening to right now, was very clear and very succinct about why some of this is happening the way it's happening. And they gave some very clear information. And so with regards to how fast and is it safe, there's better technology, it's already been mentioned. There's been global collaboration. This has happened across the world. Nothing like this has ever happened to this degree. And as a result of that, there's been 180 research laboratories that's been taken part in this, 100 biotech companies, and $24 billion has been invested to actually roll out the vaccine. That's unprecedented. So there's been a lot of tests, there's been a lot of research. People haven't been blocked by all the red tape that normally happens with getting a vaccine to the public. And that's because it was in the interest of the whole world. So those are some of the reasons that it was done so quickly and so fast. And all we need to do is make sure we give people as much information and facts so that you can make informed choices. And why, a question was raised, why is it being rolled out to the BAME community far more than others? Well, I don't necessarily think that that's the case, because there is a tier system that has already been mentioned before. And the over 70s, the health professionals, there's all the various different categories. Why there's a lot of communications and seminars and talks to the BAME community is because of understandable fears and concerns of trust, which we haven't been able to give the trust to our government for all sorts of reasons going back decades. There is a lot of talk now that the BAME community is not taking up the vaccine. And so we need to just make sure that enough information is provided so that that happens. When the government and the statistics stated that the most vulnerable category was over 70s, who would have believed 2 years ago that the government could have said that every single person over 70 needs to be shielded and stay indoors for 9 months, as it turned out, and even longer, because they needed to protect those people from those communities. When the statistics, and we were seeing all of our fellow doctors and nurses and key workers and drivers and cleaners in the hospitals, it's making it safe for us. Many of them who look like us were the ones that are actually dying the most from COVID. We were then challenging the government, and they needed to do statistics. They needed to then put things in place to support and protect. And what do? They just ordered another research and another review. So now the vaccine's out. What would we say in this situation if they had a vaccine which they were comfortable and confident with, and they then said that we were at the back of the queue for that? We would be up in arms saying, well, hang on a minute, you do realise that we are being the most affected. So why aren't we at the top of the list? So it's going in a particular tier system, and some of us appreciate it, how that works out. But we need to not convince people, not to badger people to take the vaccine. We need to just make sure all of our community are as well informed as possible so you can make an informed choice. I'm glad that mental health has been brought up in this webinar, because mental health is a huge issue. It's not going to be something that doesn't affect every single one of us, whether it's your family or your relation or your friend or neighbor or colleague. Every single person is going to be affected in some way to a lesser or greater degree by this pandemic. And so mental health is going to be a huge issue. It's already an issue. And what we need to do is make sure that we combat that. And we don't need to wait until things are reduced in terms of the numbers who are contracting or dying from COVID. Things need to be put in place now. So the government need to do that. There is a white paper that's been launched, and it sets out the proposals for legislation to reform the Mental Health Act. There's a consultation period up to the 21st of April. So I would urge you all to just Google mental health white paper, government, and it'll bring you to the site. And what it needs to do in that consultation is our communities need to participate in that consultation period, because there's things that affect our communities that doesn't get taken into account. It's the first time that there's going to be this kind of reform for 40 years, I understand. So we need to actually be part of that conversation. So please take part. As a local councillor in Croydon, what I'm trying to do is roll out as much information as possible, because a lot of this is going to fall on local authorities and people in the community. We've got an amazing group of community organisations, a third sector, who have been absolutely amazing. So we're rolling out first mental health first aid training for a lot of our community, so that we can identify the signs to support the people that's going to be affected, which is all of us, but to a greater or lesser degree. So we can then signpost and make sure people get support as quickly as possible. That's already happening locally. And I would just congratulate the amazing third sector and the community groups that are actually doing that on the ground. On a personal level, I'm not yet in the tier to receive the vaccine, but the person I love the very most in the whole world, apart from my father, who I lost at 14, is my mother. She's very ill at the moment. I'm caring for her. And she's in the very top tier. And she was watching lots of reports constantly about people taking the vaccine. And she saw people decades younger than her receiving it. And she's bedbound, so she finally received it. A paramedic had to come to deliver it to a lot of people who are housebound. And I was desperate for her to take the vaccine, and she was desperate to take it. And when she actually got the jab and the paramedic left, she burst into tears, because she now thinks that she has some bit of protection against this awful, awful virus. And I'm just waiting to take it, because I don't want to bring something home to my mother for her to contract it, because now she's a bit more protected. She may not actually have any serious effects from it. But that's just a little anecdote personally of how I feel about the vaccine, and I will take it when it is offered to me. Not that I'm 21, but I'm in one of the lower tiers. So I'm really keen to continue conversations around this whole debate, and I'll be putting on some more events myself, and I'm going to get Dr. Palmer and Dr. Mitchell, who have an amazing way of being clear and succinct on how the virus has occurred, and how we can actually combat things and how we can actually give more information to our community. So thank you so much for allowing me to speak to you here at this particular forum. Thank you.
Thank you, Councillor Cummings. I think that was a powerful message, both from the government's perspective and your personal experience. And we wish your mom a very speedy recovery. And I think the message here is, you know, allow people express their concerns, engage them in conversation, keep the conversation going. We will do whatever we can to support you in the reforms, and we will be very happy to participate in whatever discussion to further this discussion. It's, as you said, it's something that affects all of us. Thank you once again. I'm sure there'll be some questions from the audience. And finally, we have our consultant psychiatrist, Dr. Ladi Smith.
Good morning, everyone. I hope you can hear me. I've had a few technical issues today. My name is Dr. Ladi Smith, and I'm a consultant psychiatrist, and I am also clinical director for the forensic services at the Maudsley Hospital in South London. I'd like to thank the organisers for bringing this event together, in particular, Dr. Chinwe. I have been asked to talk about mental health, and I want to say that part of my role, I am the presidential lead for race and equality at the Royal College of Psychiatrists, is one of my roles. And in part of that role, which I've been doing since July 2020, is to educate and educate others and to gain more and more understanding of why it is that, and this is unfortunately true, if you are Black in the UK, if you're Black in the USA, if you're Black in a majority white country, unfortunately, it appears that you are going to be much more likely to end up at the severe end of the mental health system. And one of the questions is why that is. There've been all sorts of speculation over the years, but more and more this year it's becoming clear that there are profound inequalities that affect Black people living, certainly in the UK. It's not actually that easy a place to live. This year has highlighted, as we've heard today, the significant socioeconomic risk factors and also the discrimination that occurs that affects Black people, Asian people, and people from all ethnic minority backgrounds in the country. We know that poor housing, poor quality employment or unemployment, poorer educational opportunities are all associated with poorer health outcomes, including poorer mental health outcomes. There's also increasing evidence that being discriminated against, particularly being discriminated against because of your racial background, is associated with an increased risk of developing a mental health problem. And those mental health problems vary from common mental disorders like anxiety and depression, right the way to severe and enduring mental health problems like severe psychoses. And just to say, psychosis doesn't mean being violent. It means having delusions and having hallucinations. And unfortunately, it can, you can have short-lived psychoses that happen once and never happen again, but you can also have psychoses that happen recurrently and affect people in the long term. What's happened this year is that we have seen excess rates of mental ill health. And those excess rates of mental ill health have been associated with the social disadvantage and the discrimination. And lo and behold, what does that sound like? That sounds like the excess rates of COVID and the poorer outcomes of COVID that we're seeing in people who are more socially disadvantaged. We know, well, I mean, that's the question, you know, what does mental health have to do with COVID? Well, we know that COVID affects Black people, Asian people, minority ethnic people more than it does everybody else. We know that COVID affects people's mental health as well. Everybody's, I mean, there's a recent study showing that nearly 70% of adults have been worried or, extremely worried about the effects of COVID on their health. Recently, the Institute of Fiscal Studies showed that mental health generally has deteriorated by about 8.1% across the population. And very importantly, we know that different groups are affected unequally by the mental health impacts of COVID. So COVID affects everybody generally anyway. It increases anxiety and depression. What we've seen, and certainly the Royal College of Psychiatrists did a survey showing that more than half of psychiatrists have seen a massive increase in the rates of emergency and urgent presentations. What that means is that more and more people are turning up having tried to hurt themselves. Actually, there's a big increase in suicidal behaviour, and unfortunately, it looks like there's been an increase in completed suicide. And those people who are more significantly affected appear to be young people, young adults, and women. What we know is that even before the COVID pandemic, if you were Black, you were much more likely to have poorer mental health outcomes. We know that if you are Black, you're more likely to have poorer outcomes with COVID. And we know that COVID is associated with worse mental health outcomes. And that's not just, for everybody generally. We also know that if you had a pre-existing mental health problem, then you were less likely to get the care that you needed, and people are turning up in extremis. And as mentioned earlier by Dr. Emmanuel, there's a concern about long COVID. And it's something like 20% of COVID presentations are actually mental health presentations. And then there's also the concern that long COVID might be associated with worse mental health outcomes in addition to that. So we are looking at a mental health time bomb. Why is that important for Black people? It's important for Black people because we already had a problem anyway. And unfortunately, because there's so much stigma around mental health that people don't want to talk about it. I am here today to urge you, please, to think about your mental health, but particularly the mental health of the young people that your children, the young people that you are working with, the young people that you are interacting with in your churches, in your mosques, because they are the people who are going to be the ones who are not going to have the job security that we have had. They are not going to have, they're going to have financial problems. They are going to have all the social factors that already increase their risk of having mental health problems, added to by the effects of COVID. Black people already do badly out of mental health in the UK. We cannot allow this COVID epidemic, this COVID pandemic that we know is going to cause problems, make things even worse by not attending to this problem that is there, that is often hidden and packed away. Please, please, if you are concerned, get help quickly. You might be worried about the mainstream mental health services. There are plenty of third sector, voluntary sector supports available. You can get support through your church. You can get support through your mosque. You can also, I'd just like to let you know that there are Black mental health organisations that you will be able to get support through as well. That includes, there's a Black Mental Health Therapists Association, there's the Association of Black Psychiatrists. And if you're not sure about getting help, you can actually go to the Royal College of Psychiatrists and they can signpost you too. Your main port of call will be NHS 111. And every single area has a crisis line. Every single area has got a crisis team for mental health support. I'm going to stop now so that we can have questions, but it's absolutely imperative that we do not shirk from our concerns about mental health. As has been said again and again and again, mental health is part of all health. Without mental health, you can't have good health. Thank you.
Okay. Thank you very much, Dr. Smith. And I think for me, the key message here is that the mental health issues will escalate or is escalating with this pandemic. It needs to be addressed and we need to seek support not just from the NHS, from our mosques, churches, community centers, we've got Black, we've got Asian, third sector, community resources. We can always go to the Royal College that can signpost us to different organizations. We've got the Association of Black Psychiatrists. We support predominantly clinicians, and we hope to also support, you know, the general public with information, at least signposting you to information. So thank you to all our speakers. It's come to the end of the talk. We'll now like to have some questions, and that would be chaired by Dr. Tim Ojo. So please keep your questions coming. We've had quite a few in the chat we've tried to address, and there have been a few that have been flagged up for the panelists to address. Thank you, Dr. Ojo.
Thank you very much, Chinwe. Fantastic panelists' presentations. And it's my privilege to chair the final bit of this webinar. Unfortunately, I may offend people, not because I intend to, but we have a number of very interesting questions. We've got limited time. I think we've got about 20 minutes. And so I crave your indulgence if I paraphrase some of the questions that have been given and invite particular panelists where the questions are specific to them to address those questions. Well, the principle has to be, please make your answers as succinct as they can be. And obviously there are further opportunities for us to carry on this conversation. So without further ado, I think the first question goes to Sheikh Mohammed. It's a question around ethics and the morality of accepting the vaccination. The question revolves around the fact that we know certain countries in the world don't have access to the vaccination yet. And so they're asking, people have moral and ethical dilemmas around accepting the vaccine in this country where other people across the world don't have it. What are your views on that?
Thank you, Doc. I think it is a genuine concern, and it has also been a concern for me as a person until last night when we heard from the world leaders, including our own Prime Minister, indicating to the fact that this is going to be one of the topic of discussion during the G7 meeting. So this is one door of a hope that we hope the discussions will really be something, you know, impactful and something fruitful. Another way of tackling this is to also put some sort of pressure on our leaders, you know, starting with our MPs and, you know, our mayors, engage them, talk to them, which I am trying to do in my own way. I think that is also one way of getting our voices heard by those, you know, in leadership to do something when it comes to other parts of the world. So I think we're getting there slowly but surely, but we all need to play our part.
Thank you very much. I'll just ask you a second question that is specific to you, and then I'll spread the question among other panelists that may have views. Question is about vaccination and Ramadan. What's your sense about the theological injunctions from a kind of Islamic
Thank
faith?
you. That's a very powerful question. You know, we are only not allowed to take food supplements. So the vaccination, as far as I'm concerned from what I learned from medical experts, it is not a food supplement. So there is nothing wrong to get an injection while you are fasting, be it in the holy month of Ramadan or any other month. And I know, of course, it will pose a bit of challenge to some Muslims, but theologically, there is nothing wrong to get vaccinated while you are fasting. Thanks.
Thank you so much. I don't know whether Reverend Bell is still on the webinar.
Yeah.
Do you have any views, sir, on the ethics of accepting the vaccination? Any thoughts from a Christian clerical perspective?
From a Christian perspective, vaccination or the vaccine is a gift from God, because the medics are, well, you know, are people of faith as well. So essentially, it's about well-being. It's about not just well-being but mental health, and as I said, it's about the holistic view of the individual, not just spiritual as mental as well. And so the mental fallout from not having the vaccine actually is far wider than not you know, being helpful in helping the community. So there is no, from an ethical perspective, it doesn't actually help people, help the individuals, protect them. So, there's no reason whatsoever in terms of finding out information, there is also a lot of people who actually believe that the cell lines, the 40-year-old cell lines are they're involved in actually producing this vaccine. But this is not so. There are no issues, there are no ethical issues, there are no bits and pieces, in terms of pork or whatever involved in the vaccine. The vaccine is safe, and the vaccine will help each individual to prosper as their soul prosper. Hopefully that helps.
Thank you very much for that exposition of your position. I think the summary from the two ministers of faith is that there are no injunctions against taking the vaccination, and indeed actually there's a moral duty in terms of accepting it as a gift of science, also understanding that in protecting yourself, you're protecting others. So thank you very much for that clarification. Next question is a more collaborative one. It comes from a GP, and I paraphrase, and the essence of the question is around how do GPs and secondary mental health care professionals like psychiatrists work together to give those with severe and enduring mental illness access to the vaccination. So Dr. Concord, Dr. Lade, other clinicians on the panel, do you have views on what's your sense, what are your ideas around the collaboration required between primary mental health services, secondary care, and primary care physicians in getting those with severe and enduring mental illnesses access to the vaccination? So let me start with Dr. Concord, and I'll go to Dr. Smith.
Hi. So as GPs, we prioritize like those that have learning difficulties. They were part of the clinically extremely vulnerable. And for those of them that could come to the vaccination centers, we booked them in and they had that. And those that could not, we actually sent people to their homes to get them vaccinated. And that is why I was saying about access. At the moment, we have various ways everyone can get access. So if it is possible for you to get to a vaccination center, we'll get you booked in there. If it's not possible, we get you vaccinated as close to your place of residence or where it is comfortable for you as possible.
Okay, thank you very much for that. So what you're saying is in your local system, based on kind of hub arrangements, you're able to work with people with segmented special needs to get access to the vaccine. I think
absolutely.
That leads me to Dr. Smith. Dr. Smith, what are your thoughts about, from secondary care physicians' perspective, integrating or collaborating with primary care to get access to vaccinations for our patients with severe and enduring mental illness?
Okay, so I'm glad that Dr. Concord talked about people with learning difficulties, because obviously most of those people are in the community and have nothing to do with mental health services. But for us, we have, for our inpatients, what we have been doing actually is providing all the inpatients who have severe mental health problems with vaccines. We did a lot of work basically lobbying and advocating for people with severe mental health problems to be put on the list, at a priority list, and that has now been done. And so that was one of the biggest things, because that policy change meant that people were now put in priority group 6, which means that if you're in priority group 6, then automatically you get sent a letter from your GP to come and have the vaccine. What we do from the secondary care point of view is if we have patients with severe mental illness who are in the community, and most of our patients are, then we would facilitate those people going to their GP or the vaccination centres to get their vaccine. But for people who are inpatients with severe mental illness, then we've actually been providing vaccinations for them whilst they've been inpatients. But as Dr. Concord says, that's different to the people with learning disabilities, most of whom are in the community and don't have anything to do with mental illness.
Thank you very much for that. Next question, I think I'll aim at Councillor Cummings, and it's about what's your sense of how to encourage conversations between or transgenerational conversations with particularly focused on younger folk from Black and minority ethnic backgrounds around the whole notion of vaccination, around the whole notion of keeping themselves safe. Any thoughts about initiatives, or how to get that going, so to say?
Yeah, it's really important to get that message out. I totally agree. So we're doing some things across different boroughs, to be fair, where we're trying to, first of all, engage with the older population, those that are, especially from the BAME community, who are a little skeptical for all sorts of valid reasons. We should never not take into account that people's feelings. But we're rolling out this mental health first aiders as well, and that's to again talk to people, and some of those are from the younger generation. We're trying to talk to all the various different generations as to how the vaccine is going to help to reduce the pandemic, and how we actually can get back to this new normal. But in doing so, it's having those conversations with the intergenerational conversation, because we've got a younger generation who are very much into technology and all the virtual platforms, and our older generation who, to be fair, they're getting akin to that as well. But it's about having that intergenerational conversation. And what's really persuasive, I think, it's those people who may have been skeptical to begin with, who then, because maybe they've lost a loved one, maybe because they've heard more information and they've made that decision to take the vaccine, or their parent or their grandparent or a loved one who's got an underlying health condition, and they then see the benefit of it. And those people who are now championing and advocating and speaking to others, because there's nothing better than a testimony from somebody who look like you, who've had the same feelings that you've had, that can then talk about their issues that they had and how they've overcome that. So we're trying to roll that across the borough, trying to do a little bit more work, and we're trying to link in with various different people borough-wide as well to try and get that message out. So it's important. It's got to be intergenerational, I think. But yeah.
Thank you so much, Councillor Cummings. I think you highlight the importance of social media and the new ways in which digital natives communicate. I've got some technical questions, and I'm going to aim the first one at Dr. Oti and then the next one at Professor Emmanuel. So Dr. Oti, there's a kind of provocation in the question here, so I'll try and take the sting out of it. Well, what it purports to suggest is that only, I don't know where the data came from in this question, where it says about only 47% of doctors or medical practitioners have taken the vaccination. And I know you have taken it and you've been a champion for the BAME community. What are your thoughts, not so much about the statistics, but what is it about having an increased proportion of medical practitioners who are visibly from minority backgrounds and enhancing and engendering people committing taking the vaccine? So any thoughts you have on that matter?
Yeah, so I just responded to something in the text, and I would like to just use the point to tell everyone that, look, the statistics will depend on the time it was taken. So yes, it's very correct that healthcare workers, look, at the end of the day, I'm Black, I'm of African origin first. That's, before I became a doctor. And yes, I had my concerns, and lots of my colleagues had their concerns. But in my trust, for instance, we're publishing the numbers, and what we're seeing is that the numbers are changing. What we're seeing is that people are listening. And I don't know when that figure was published, but what I can say for definite is that the numbers are going up. So the healthcare workers have their, have their cultural backgrounds. They're members of churches and mosques, so they're still subject to all this. Sorry, they're subject to this. Sorry, if you mute. So they're subject to this. So they're subject to. Thank you. So sorry, so healthcare workers are subject to the doubts as well. But what I can say for certain, the work that I'm doing in my trust with my fellow Black doctors, we are definitely speaking, and people are so encouraged with the fact that they're finally seeing people, for want of a better term, that look like them, that are saying to them, look, I understand where you're coming from. All these charts, all these concerns, I understand, but you know what? I took the vaccine, and I'm just saying, and just to point out one of the charts, I understand what you're saying. I don't do those that took the vaccine versus those that didn't. I don't do that. What I do is this: let's just keep talking. Let's just keep engaging. Let's just keep addressing the things. And I promise you, I understand when we had the first big meeting in my hospital, the way let me use the way my origin is Nigerian. The way the Nigerian man likes to hear something, yeah, he likes to hear it 3 times. I would tell you 3 times, but I'm confident that we are beginning to turn the tide. And the term I use is let's keep talking. So yes, there was initial hesitancy amongst Black people, and we have to be admitted, because amongst Black doctors, sorry, but we are Black people, first of all. But definitely now it has changed. And definitely the figures in my trust that were released on Friday were so encouraging, it's giving us a boost.
Thank you so much, Dr. Oti, and I appreciate you handling that kind of reverberation. Next question is Professor Emmanuel, if he's still there. Thank you very much for your kind of very clear exhortation earlier on. The question I have also is a technical question. I've taken the liberty of paraphrasing it. 2 bits. One says, would it be useful, what's your opinion about publishing phase 4 trial data on the results of Black participants? And secondly, I think there's a question you might help us cast further light on, I think has been answered in public and the media recently, but further emphasis is required about the gap between first and second doses, where there was this big palaver about initially 3 weeks extended to 12 weeks. So first question, phase 4 trials. Second question, gap between first and second doses. Thank you.
Yeah, no, thank you for paraphrasing. So I think the question about the phase 4 stuff, I think that is incredibly important. I'm a believer, my academic bent is that we should always be looking at real life experience from the practical, financial, health, economic part of practice, but in particular with regard to this, given the hesitancy that we've seen amongst communities, I think there's a real need to get the kind of granular stuff, and especially if we're talking about something which is essentially global. This is a global pandemic, so our understanding of how it affects communities in this sort of multicultural communities in the Western world that we live in, I think getting as much detail about populations, whether it's care home populations, specifically whether it's BAME populations, all of that stuff, as grainy as possible, and specifically even more grainy, looking at Black experience versus Asian experience, etc. I think all of that is unbelievably critical, and phase 4 studies should be done. And it's an embarrassment to me that many organizations, many trusts didn't get that set up proactively to collect their data on BAME people. It came as a late reminder, and that's just an example of how we have let Black and minority people down. With regard to the question of how this gap thing, I think again and again, I've got no loyalty to the government. My loyalty is to the science and to the people I happen to look after. The science was very explicit that when the studies were looking at how immunity works in terms of having a booster response, it's always been optimal between the 3 to 6 week mark. The booster response in response to an initial priming dose of antigen is to get a peak around 3 to 6 weeks. There's no reason why coronavirus should behave any differently. What's interesting in some of the post hoc phase 4 type analyses that have been done on the AstraZeneca vaccine is that there seems to be a greater benefit in terms of immune activation, not in terms of the data on getting infection, but in terms of the immune response. The blood response seems to be greater in patients whose second vaccine was delayed 8 to 12 weeks. That hasn't been shown for the Pfizer vaccine. It's an assumption that's being made that it's a way to basically cover a bigger population in the time when we don't have enough vaccine to go around in that way. So I think we have to follow what we're allowed to legally by the government. So we're stuck with this. There may be some benefit for the AstraZeneca one to have been prolonged a little bit, which is not something that was known about, but it's just emerged in later data. But ultimately, we have to do the best we can and accept that maybe 60% protection is the best we can do until we get that second dose.
Thank you very much, Professor Emmanuel. There are a few questions that have come on, which I think I will just summarize and probably end the session because we've been at it for a while. And I think if anybody has any quick comment, probably one sentence, you can pipe up when I lay out what's been put out. One of them is trying to determine or to decide whether there's some kind of biologically determined difference in susceptibility to the virus, as opposed to social structural and the power of structural and systemic racism. And the other one was, I think, a more provocative one, where I think actually maybe the facts underpinning the question are not actually sound. And it's about saying, if you say that having the vaccination doesn't stop you getting it or stop you transmitting it, why are we bothering ourselves talking about the vaccination? I think there's a question as to whether New Zealand has had instances of COVID, and I think that they have, but much less, and there are challenges around whether they closed their borders much earlier and had more stringent, and obviously issues about geography. They're a different part of the world, so people wouldn't necessarily cross their boundaries as easily as those where there's more interconnection. So I think 2 minutes, anybody, any quick final comments? And in order to prepare you for your final comments, I'll just say 2 things. There's increasing research around the behavioral science understanding of why people might have divergent views towards accepting the vaccination. One of them is something called reactance, and reactance essentially refers to psychological resistance to feeling that you're being put upon by an organized body. And so reactance may be a reason why some people in our community find it difficult to accept, particularly if they think the governments don't always look out for their own interests. The second one, which I think is more important, and why I'm addressing this, is people have the right to have their views. And they also have the right to have views, whether it's based on fear, fact, hope. But what I think is important is we need to ask ourselves as individuals, as members of communities, why we have those views. And there's something called motivated reasoning. That is where you use your emotions to make sense of the facts and arrive at answers that are fitting with your emotions. And I think it was John Hume who said something around reason is a slave to passion. So no matter how logical we think we are, we always use emotions as part of our decision making. And ultimately, I think we are having these conversations and will continue to have conversations around the importance of protecting ourselves as a community, addressing structural inequalities, and providing the circumstances for our children and ourselves to flourish. So it's been a privilege trying to kind of go through the question and answer at the end. If there are any final comments from any of the panelists, please feel free to make it, as long as it's short. And then once you're done, I can then hand over to my colleague who will bring the session to an end. So I'll just run through the panelists.
Sorry, thank you very much, Tim. That was really, really well said. And I'm going to just give my own final comment so everyone can do this. Look, my message is very simple. And that is that if it's the vaccination, well, first of all, I said COVID is real. And for all the concerns of the vaccination, everyone you mentioned, I completely agree with you. But what I would tell you is that those are all concerns. But what I know for certain is that the COVID is killing us now. So all I can say for this is, please, let us just continue to engage, and let us engage with the right channels. And after this is going to go on for a very long time. So let us start. But I think that finally we are in a position where we can actually influence healthcare, the gross healthcare inequalities in our population. So let us continue. So please, no question is silly. Ask any question you want. It doesn't matter to me. I mean, I can ask it 4 times, but please just come to the right people for the information. And I'm very, very glad to see that Black people from the community are coming together to address because we care about everyone, and that is the reason why we're here today. So let's keep talking. Thank you very much.
Thank you very much. Reverend Bell. You need to mute me.
Yeah. Let me just say that, I saw someone put in the chat about the mark of the beast. Come on, let's just be sensible. There's nothing to do with the mark of the beast or any theological antecedents for this. Let these people just be sensible. This is a pandemic which is affecting people, Black people, more than anyone else because of historic antecedents. We as Black people have to wake up and just be sensible about what we're doing, and don't spiritualize everything, and take the vaccine and protect ourselves and our communities.
Thank you very much, Reverend Bell. Sheikh Mohammed.
I must say thank you so much for organizing such a very informative session. My last message is that let's keep talking and keep creating awareness. Things are going to get better. We should not get discouraged. As panelists, as medical experts, as religious leaders, keep knocking the door and insist on knocking the door. Eventually, the door will be opened. And last but not least, to all our participants, try as much as you can to verify every message that you receive, either via social media or via any other channel, with the trusted medical experts. By so doing, we'll be saving our lives and the lives of those around us. Thank you so much. May God bless you all.
Thank you, Sheikh Mohammed. Dr. Smith.
So actually, I'm just going to say very quickly, there's a comment in the chat about if COVID affects Black people more than other people, then maybe the vaccine will too. The reason COVID affects Black people is it's not genetic. It's like with mental health problems. It's not genetic. What we know is that these are social factors. It's social disadvantage. And COVID affects Black people more, it affects Asian people more, it affects white Eastern Europeans more. And it's because of working in frontline services. It's absolutely imperative that we understand that the higher mental health risk, the higher COVID risk is because of social disadvantage, and that is driven to a large extent by discrimination.
Thank you very much.
And yeah, and I just wanted to say very, very quickly, if you don't have the vaccine, then all that's going to happen is there's going to be another big stream of discrimination. I've had my first vaccine. I was really happy about it. Very relieved indeed. And I can't wait to get my second so that I can go and see my parents.
Thank you very much. Professor Emmanuel?
Thanks. Sorry. I mean, listen, the main thing I would say is that it's brilliant that we are making ourselves available for these conversations, and that's what we need to carry on doing, because having people who look like us being able to answer questions, and it feels that it's people are more likely to, number one, ask them, number two, more likely to get a response which actually resonates with them. So thanks for hosting this, and I would say above all else, please feel free to raise any questions. I'm sticking my email address in the chat if anyone has any particular questions about up-to-date data from NHSEI about vaccines, and yeah, I look forward to interacting. Thank you.
Thank you very much. Councillor Cummings.
Thank you. I would just like to thank the Association of Black Psychiatrists for putting on this event. There's been very many, and I'm so proud that lots of Black and Asian doctors and scientists are actually rallying around to give the information to our community so they can make informed choices. I'm not going to repeat what's already been said because I'm in amongst illustrious health professionals here. Dr. Smith, you're absolutely right. We need to make sure that we talk to people. We need to make sure we get the right information. We get signposted to receive this information, especially about mental health as well. But all I'll say is, yes, we need to keep talking. This is not going away. We need to make sure that we're protected as a community. So just every single platform you can, speak to your GPs, social media, the right social media, speak to people who know what they're talking about. But please, please, no one's forcing anyone to do anything they don't want to do. We just want everyone to make informed choices for the health of our nation. So thank you for having me here with you.
Thank you very much. And finally, Dr. Okonkwo, and once Dr. Okonkwo finishes, then she can hand to Dr. Quento. So Dr. Okonkwo, last but not least.
Okay, thank you everyone, and thank you for such an informative seminar. What I have to say is, like Patsy said, we are here, we are your GPs. You've always trusted your GPs, you've always trusted your medical experts. If you have any questions in the community, we are empowering GPs to have the time to answer your questions. Please ask your GP. For those that have severe enduring mental illnesses, they are in our cohort 6. We are vaccinating them now. So if you know anyone who has severe enduring mental health problems, we are more than happy to vaccinate them. For those that are not permanent staff, because that's another thing that came up, we are vaccinating everyone listed as a frontline worker, permanent, temporary, one-day work, you are eligible to have the vaccination. The most important thing is make an informed choice, get the right information, empower yourself, protect your family, and protect your community. Thank you.
Thank you. Dr. Quento.
Wow. Can everybody hear me?
Yes.
Yeah. Wow. Thank you so much, everybody. It's been a very interesting time of discussing with everybody. I just wanted to start off with thanking everyone for coming together. And I wanted to start with an African proverb, which says, if you want to go fast, go alone. If you want to go far, go together. There has been a wealth of information shared amongst us today. And I just wanted to thank everybody that attended today, because for you to have conversation, you have to have people with you. If you don't have people, there is no conversation. So thank you to everybody that attended. You provided richness to the conversations we had today. Thank you to our speakers who provided a wealth of their experience and expertise. I also want to thank the Association of Black Psychiatrists in the UK partners, individuals and organizations who supported us along the way. Your immense contribution has made today, the conversation we've had today, very successful. I want to thank every member of the Association of Black Psychiatrists, people working behind the scenes that made today possible, the logistics work group, the publicity, the planning group, everybody that worked hard to get today to be successful. I want to say thank you. I hope by the end of today, we've gone away with information that can help us make an informed choice with regards to the vaccine, understand the mental health effects of COVID, because that has been missing in conversations that we've had in every sphere or most spheres. And most importantly, carry on the conversation with others, because health is our greatest asset. That is one of the quotes we have. Without health, we don't have anything. So please, let's carry on the conversations. Take care and stay safe, everyone. Bye-bye.
Just to reiterate, thank you for attending our webinar. Have a good day.